But this is an issue that I care deeply about, so I'm here to share my story, what I know, and to ask you to treat this crisis with the integrity that it needs. Here is my key message. The cause of today's crisis is contaminated street drugs provided to Canadians by organized crime. Full stop. Luckily for me, when I started using substances in 1981 to deal with depression, suicidal thoughts at the age of 12, street drugs were not yet contaminated with unknown quantities of fentanyl, benzos, and xylazine. By my 20s, I was addicted to heroin. I was navigating the hierarchies of prison, gangs, seeing death and violence, facing threats to my safety, my life, and dealing with extreme challenges of living on the street. I was able to survive all this in part because even though they were illicit, I knew the drugs that I was consuming. When North America's first supervised consumption site opened in 2003, my life changed immediately for the better. At Insight, I received clean needles, which reduced my risk of overdose and cutting my risk of dangerous infections. I got health care, support services, and every time I asked for it, I got help entering detox and treatment programs. Insight's records show how I used this harm reduction facility more than 4,000 times in 10 years. I know some of you think I don't deserve that level of support, that I should have been left to die from my trauma, my addiction, and my choices. But my wife, my 3 kids, and the people I've supported into recovery, and many of the youth I've helped redirect would disagree with you. Maybe even the mayor and the council of the city of Vancouver would disagree too. Since last month, they declared a day in my honor for all the work that I do at helping people. I've experienced multiple overdoses at Insight, including my last 2 on the same day in 2013. All overdoses were reversed with naloxone. That staff group there saved my life. It's probably not a coincidence that fentanyl first appeared in BC in 2013, but I don't know if it was in the drugs that nearly killed me. This was also the year after many attempts that I achieved recovery and it stuck. If I hadn't, I wouldn't be here to talk to you today. The heroin I was using, which killed 334 people in 2013, has now completely been replaced by the drug supply and ever-changing toxic mix of fentanyl and other adulterants. This was a massive jump in potency, and supply chains were interrupted during the pandemic. Last year, in 2023, toxic drugs sadly killed over 2,500 British Columbians. That's more than 7 times the number of deaths. And with that comes an equal increase in related physical and brain injuries, pressure on first responders, healthcare, recovery programs, impact to public safety, and to our communities. More than 7 times the impact in 10 years. That's over 600%. We don't have the resources or people to deal with such a huge increase over such a short period of time. This deadly trend is repeating in every province across Canada, in every community in North America, regardless of drug policies, which brings me back to my key message. This is a toxic drug crisis. It's not a policy crisis. It's not an addictions crisis. It's not because of wacky people or wacky ideas. It's not caused by harm reduction, safer supply, or decriminalization. And every single one of you knows this. You've heard from over 50 witnesses and received 20 briefs. This must be clear acknowledgement that toxic, illicit drugs are the cause of this public health emergency, and the public must be informed and warned about the real risks that lie. You are hurting people when you say otherwise. Different experts have different ideas and solutions. But if there is no agreement on the cause of the crisis, then your work here at this committee is absolutely pointless. Only from shared understanding can real solutions, rather than campaign slogans, be developed, debated, and decided. Thanks for your time, and thanks for listening.
Thank you very much, Mr. Felicella. And now we'll turn to Dr. Tu. You have the floor for 5 minutes, sir.
Thank you, Guy. I'm calling in from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. Thank you, honorable members, for this opportunity to speak with you. Allow me to begin by situating myself in the work that I do. My name is David Tu. I am a non-Indigenous family physician, and for the past 24 years, I've worked as a family doctor in Vancouver's downtown east side with a dominantly Indigenous practice. I'm grateful for the last 4 years to have been recipient of a Health Canada SUAP grant, which has allowed me to explore the impacts of partnering Indigenous elders with primary care providers to deliver service to Indigenous peoples living with opiate use disorder in an urban setting in a meaningful way. I currently work at the Kilalalam Health Center in the downtown east side. As Guy just said, we are 8 years deep into a public health emergency in British Columbia, resulting in the deaths of 7 individuals per day due to an increasingly toxic and unregulated drug supply. Indigenous people living in the downtown east side are at the epicenter of this crisis. To illustrate this, I just want to share a story that highlights some of the complexities of the situation. Miss M is a 38-year-old Indigenous woman of Métis and First Nations ancestry. I've known her and she's been a part of my practice as a family doctor for the past 14 years. She's a mother of a 3-year-old son. She's an incredibly witty and fiercely loyal human being. She's also endured extreme levels of trauma in her life and lives with a long-term severe substance use, opiate, and stimulant use disorder. Ms. M, for the 2 years after her infant son was taken from her and removed to care, Ms. M expressed no interest in controlling her substance use. Despite the support of her family and a dedicated care team, there was minimal engagement in opiate agonist treatments and only sporadic engagement in prescription alternatives. During this 2-year period, she experienced multiple overdose events. She could easily have died and been just a statistic in the sheer volume of Indigenous people dying each day in BC. Yet with an increased sense of hope for reclaiming her role as mother to her son, I'm pleased to say that Miss M is now engaging in care and is on a fentanyl patch-based OAT program that has allowed her to significantly reduce her illicit opiate and stimulant use. She is currently motivated to attend an Indigenous family-centered residential treatment program with both of her parents, her sister, her partner, and their son. Sadly, the only 2 Indigenous-specific treatment centers in BC that will accept families will likely reject this family. One because they exclude people who are receiving OAT, and the other because they do not allow children under 8. We are hoping for an exception, but both centers have a 6 to 12-month wait list, and this is a harsh reality for this family. 8 days ago, Miss M was discovered unconscious in a bathroom in her mother's apartment building. Thankfully, she was resuscitated, and she recovered in the emergency room. Let me just say a statement of fact that the unregulated drug supply is killing people, and First Nations people are at 6 times the risk of death compared to non-Indigenous people in BC. To paraphrase Elder Bruce Robinson of the Nisga'a people, you can't help people if they're dead. Many individuals with substance use disorder are not ready to address their addiction for a variety of reasons. This means oftentimes treatment services are unlikely to bring about a recovery for them, similar to this Ms. M in the 2 years following the removal of her child. However, alongside other harm reduction initiatives, prescribed alternatives and opiate agonist treatments can help reduce the risk of overdose. However, it is widely agreed amongst medical professionals like myself that we can't prescribe our way out of this public health emergency. There are several things that we collectively need to do to change course. The first is a fully functional continuum of care from harm reduction to recovery-oriented treatments. The second is a pathway we can all be on to a regulated drug supply. We must also acknowledge that culture saves lives. For Indigenous people specifically, whose route to addiction was often paved by the trauma resultant from colonialism, traditional medicines and cultural practice offer a meaningful means for many to gain control over their substance use and address the underlying causes of their addiction. The third need is for more investment in programming focused on culture, traditional medicines, and land-based healing. To be clear, we need investment in treatment programs. For Indigenous individuals like Ms. M, who are prepared to address their substance use, there's a need for increased access to culture-appropriate residential and community treatment. Lastly, and importantly, we must put an end to the false dichotomies and divisive politics. I think I couldn't say it better than Guy. We are a country of abundant resources, and the COVID-19 pandemic revealed our capacity to mobilize resources in response to public health needs. We need harm reduction services, including prescribed alternatives, to keep people alive.
Dr. Tu, I'm going to have to interrupt you. You'll have lots of time to expand on your ideas as people ask you questions, but your 5 minutes is over, sir. Thank you. Next, we'll turn to Mr. Williams. You have the floor, sir, for 5 minutes.
Okay, well, thank you. Un grand merci pour votre accueil. Thank you very much for your warm welcome.
My name is Dan Williams. I am the Minister for Mental Health and Addiction for the province of Alberta, and I'm a policymaker. I don't have lived experience. I haven't worked on the front lines. I am someone that gets to decide with my cabinet and with my colleagues in Alberta how to respond to what is an addiction crisis that is ravaging Alberta and our families and our communities, but across the entire country. We see the same direction happening. And so you being the opioid epidemic and drug crisis committee appointed to investigate this, I think it's important that we frame it in the appropriate way. The reason that we have overdoses as we do, the reason that we see this tragedy unfolding in our families and our streets is because of a disease. It's a deadly disease of addiction, and it doesn't discriminate on who you are, and it can affect anyone. The reality is that addiction has one of two paths, only one of two ends, run its course eventually. And anyone that tells you otherwise is lying to you, and they could be lying to themselves. But there are only two ends to addiction. And as a policymaker, as a province, and as a country, we need to accept this reality. It either ends in pain, misery, and tragically, given enough time, death, or it ends in treatment, recovery, and a second lease on life. And that is why Alberta cares so passionately and believes we have this obligation to care for those who are in a vulnerable position, those who are suffering from this disease of addiction that could end deadly or could end in hope and renewal, to be family members again and brothers and sisters and fathers and brothers, to allow us to have a vibrant community with these individuals recovered, fully contributing again to those wonderful parts of our community that we love so much. And so Alberta has invested a huge amount of resources to build this out. We understand that we have a choice. We have a choice as a province, just as we do as a country, between continuing down the path that we've seen for, let's say, the last 25 years in Canada in terms of a policy setting, which is not producing the results that we need. Our communities are increasingly unsafe. Individuals who are suffering from addiction do not get the dignity and the care that every one of them deserve at the opportunity of recovery. And I think we, all of us, and especially you in this committee and those responsible for making the federal policy, have that same moral obligation and share that I have as a minister in the province of Alberta, that each citizen of our country has, to want to see our communities improve and the dignity of everyone respected and cared for. And so to give you some idea of the work we've done, we've invested, by the end of it, probably close to $1 billion in capital. We're working towards that end when it comes to building the infrastructure. Alberta, along with the rest of the country, for many years, had not built out the treatment capacity needed. We need to have an off-ramp out of addiction. If we see an increase in addiction happening, whether we talk about the oxycodone crisis that propagated much of the opioid pandemic that we saw and still are in the midst of, and we talk about meth or cocaine or any other substance, even alcohol, we need to have a path for people to leave addiction and end up not dead, but in recovery. And that is why we've invested in 11 recovery communities across the province, 5 of which we partnered with Indigenous communities. 4 are on the reserve of the Indigenous community, knowing that they are disproportionately affected by this deadly crisis of addiction, and we need to step into that space, not waiting, but rushing in to support them in how they see, as we heard previously, culture is an important part of that land-based healing and culturally appropriate healing that goes along with the Indigenous community in Alberta. We have obviously invested not just those 11 recovery communities for a full continuum of care, but we meet people where they're at. And our system funds millions of dollars of drug consumption sites, of naloxone kits. We have the therapeutic living units in our correction facilities, so we have access to treatment, which I know many of you got to see when you generously came to Alberta to see our program. When it comes to the path forward for Alberta, when it comes to the path forward for Canada, my request to each of you is to take, as we heard from earlier testimony, very seriously this crisis. We cannot continue with experimentation like decriminalization, which happily we've seen walked back in Alberta. We, in Alberta, are opposed fundamentally to a policy like Safe Supply that hands out drugs to drug addicts in an attempt to deal with an addiction crisis. We believe in hope and opportunity. We care about the compassion you need to care for those individuals who are struggling. And we ask as well, as a federal body responsible for First Nations, that you come to the table and do not avoid your obligations with First Nations. Partner with us and the First Nations to provide hopeful solutions. Thank you for your time, and I look forward to answering your questions.
Thank you, Minister. And now we will hear from Dr. Goulau. Dr. Goulau, you have the floor for 5 minutes.
Thank you, Chair. It's an honor to join this committee. And I will take my 5 minutes to, first of all, to start by trying to destroy some myths around the so-called Portuguese model. Because I'm aware that the way that Portugal used to address the epidemic on heroin in the 80s and 90s is quite often described as a mere decriminalization or more than that, than a liberalization of drug use. But it's far more than that. On one side, we did not liberalize the use of substances in Portugal. Drug use is still prohibited. It's not a crime. People do not undergo imprisonment penalties, but there's a set of administrative sanctions that are used to deter people from using drugs. On the other side, decriminalization is only one part of the system that constitutes a continuum from prevention to treatment, harm reduction policies, and reintegration. And even if I consider that decriminalization is a very important part of it, it is mostly a way to touch people, to get in touch with people that otherwise do not approach the health system or do not search for any kind of support to change their lifestyle. With the complete set of policies that we had put in place, and I was happy to share, to have the opportunity to share to Minister Dan Williams and his staff a couple of weeks ago what we do here. With that, we managed to stop an epidemic that I compare to the one that you are living in North America related to fentanyl. It's cross-cutting all layers of societies, affecting all families. I believe that is almost impossible to find a Canadian or American family that has not been affected by this epidemic. And I think this is the way to completely change the way to address this, those problems, to consider drug-related diseases or drug use disorder as a disease with the same dignity as other diseases, and people who suffer from it with the same dignity as patients who suffer from other kind of diseases. I think it's key to consider and to approach those problems under the health and social side, rather than prosecution, rather than any kind of coercion over people who have this kind of problems. So I'm very happy, and I'm completely at your disposal to reply to the questions that you may have around the Portuguese way to address these problems. Thank you for having me here.
Thank you very much, Dr. Goulau. And now we will turn to rounds of questionings. We will start with the Conservatives. Ms. Goodridge, you have the floor for 6 minutes.
Thank you, Mr. Chair. I'm going to start out. I just want to thank you, Mr. Falatella, for being here and sharing so bravely your story. And I'm glad that you are here to tell your story, and I'm glad that you are alive. And it does prove that recovery is, in fact, possible. I'm going to start my questions to Dr. Goulau. In your opening statement, you said that in Portugal and under the Portuguese model, you didn't liberalize drug use, and that decriminalization was just one aspect. In Portugal, if someone were to be smoking crack on a beach, what would happen to them if a police officer were to come around?
Thank you for the question. I don't know if I must reply immediately, Mr. Chair.
Yes.
Yes.
Yes, please,
Okay,
sir. So we do a bit of a back and forth here, and the total amount of time for each party at this time is 6 minutes.
Okay. Well, if someone is using an illicit substance in a public place, the police authorities may intervene, may take this person to the police station, apprehend the substance or substances that he or she has, weight it, and if the amount of illicit drug that the person has with him is superior, is more than the considered adequate for personal use for 10 days, the person, there's the presumption that this person is smuggling drugs, is trafficking drugs. So he or she will be sent for the criminal system as before. But if the person has less than that amount, adequate for personal use for 10 days, is just intimated to present before an administrative body, the so-called Commission for Dissuasion of Drug Addiction, which is a body under the Ministry of Health that has the power to apply administrative sanctions similar to those who are used to traffic problems, such as do not use the safety belt or things like that. But the main task of that commission, which is composed of health personnel, is to assess what kind of needs does this person have related to drug use. If he or she is an addicted person, is invited to join a treatment facility, and the Commission has the possibility to facilitate the access and to turn it very, very simple.
So in British Columbia, they embarked on a very radical drug legalization project where they effectively removed all tools from the police to be able to do anything with public drug use. And they've recently rolled some of that back because it was an abject failure leading to skyrocketing addictions. I noted in a 2018 Vancouver Sun article, you said that decriminalization is not a silver bullet, and that if you decriminalize and do nothing else, the problem will get worse. And that's exactly what we saw happen in British Columbia. You talked about the dissuasion committee. How exactly does that work?
When the person comes to that commission, there's a technical staff with psychologists, social workers that collects an history for the person, trying to identify the needs and to understand if the person is in fact addicted to substances or is a mere recreational, occasional user. In any case, if the person has an addictive disorder, is invited to join a treatment facility, but it's not compulsory. Okay, so there's some work of motivation to address people to treatment. But most of the people who are present to those commissions are not addicted. In fact, they are most of them are users who are not really problematic. But the aim is to intervene before they become problematic. So to act in any factor in their lives that may lead to a more problematic way, to a more problematic use later on.
So in Canada, they have a program that's called so-called safe supply programs, and they give out sometimes upwards of 30 hydromorphone pills per day to people that are struggling with addiction. Is this something that is happening in the Portuguese model?
No, ma'am.
Do you think that it is a smart idea?
Well, I don't dare to. Our realities are quite different, but in any case, we use plenty of substitution opioid treatment with methadone, buprenorphine, but we do not have this kind of safe supply policy that you are experimenting there.
And what is the breakdown?
Thank you, Ms. Goodridge, and thank you, Dr. Goulau. That's the end of your round. Next, we'll turn to Dr. Pawlowski. Dr. Pawlowski, you have the floor for 6 minutes.
Dr. Tu, you mentioned land-based treatment in your testimony. One of the purposes of what we do is to eventually come up with a report and recommendations to the government. So I want to hear more about land-based treatment. Are you using it? How successful is it? What evidence is there that it's successful? And do you think we need to put more resources into it? Certainly my impression is that for Indigenous people, this holds a lot more promise than a lot of other forms of treatment.
Well, thank you very much for that question. And I should acknowledge that I am partnered and work alongside many experts in Indigenous medicine practice, cultural practice, and land-based therapies. But myself, I'm not an expert in those modalities and those therapies. But I have witnessed their impact. In terms of evidence,
Dr. Tu, can you just tell us, like, what exactly is it? Like, if somebody goes into land-based treatment, I think I kind of know, but you go out to the land for a couple of days, or weeks, or how does it work?
To be honest, there's a lot more complexity than to give a simple answer that it is just this one thing. But it is fundamentally, I would say, about connection. It's about relationships, and one of those relationships is to the land. I think conceptually, from the teachers that I've had, from Indigenous elders and providers, is that the solution towards addictions focuses around relationships more than substituting other therapies or other modalities. And relationship to land is a really important relationship for many Indigenous peoples and cultures. So establishing those reconnections, along with the reconnections to who you are as an Indigenous person, to your family, to your ancestors. These are the connections that actually draw people into a positive state of identity as a human being. And people who acquire that state, a good relationship with themselves, a positive outlook, tend to make affirming positive choices for themselves. And it's those relationships that support them to make choices, such as decreasing the use of harmful substances to their body. So I've seen it play out as people going on a canoe journey, people actually just making daily walks to the beach in our neighborhood to connect with the ocean. There's many ways to reestablish those relationships, and there's many very sophisticated Indigenous modalities from Indigenous medicine providers to actually bring about those reconnections to the land and that meaning. So I don't want to belittle the sophistication of Indigenous medicine practice, because it is that sophisticated, but it is lots of evidence that this is a pathway for many to change their substance use. And so yes, I would definitely wholeheartedly endorse greater investment, both in developing the protocols and in developing the resources.
And Mr. Williams, perhaps you might comment on it too. Would it be your recommendation to put more resources into land-based treatment?
Thank you for the question. And I think that land-based treatment, especially from an Indigenous lens, is a central pillar to how we look at recovery as an opportunity. We believe every single Albertan who suffers from addiction deserves an opportunity at recovery. And we see really great outcomes when you look at therapeutic living communities or recovery centers, which land-based treatment would be specifically within. When it's paired with opioid agonist therapy, the data is clear on that in terms of research, and also our outcomes point to that as well. I understand you had Dr. Day present as well to this committee, our head of addiction medicine. We've partnered with 5 Indigenous communities, 4 on reserve, where it really is not an imposition of this is what you're doing, but a proposition of how do we partner together for nation-to-nation conversation around every single First Nation chief I speak to. Every time I go onto a reserve, they're asking for recovery treatment capacity. They are asking for that. They are saying, please, they understand that there are the marketing terms around safe supply, et cetera, but they see past that because they see the carnage in their communities, and they are saying, please, please help us with this. And so the province of Alberta had said, even if it is federal jurisdiction, this is a community problem that we need to step into to work with them on. So we've invested $35 million approximately in each of these recovery centers, plus the operation costs, where they will be owned and run on reserve by First Nation, culturally integrated, and we think it's a central piece in how we look at addressing the crisis.
Thank you. Dr. Goulau, you talked about the commission that people have to appear before if they're caught with drugs. What happens with the problematic users who don't agree to any sort of treatment, who don't agree to go to use opioid agonist treatment or to attend some sort of therapy? What's the next step, or is there a next step?
Well, the attempt is to motivate the people with problematic use to attend or to join a treatment program. But if they are free to refuse. And then in the first contact with users, the only recommendation that is done, please do not come here for the same reason in the next, let's say, 6 months, for instance. Because otherwise we'll have some kind of penalties.
Okay, so there are penalties, and what are those penalties?
Dr. Pawlowski, maybe you'll hold that question. I'm sorry, Dr. Goulau, the time for this round is over, but there'll be lots more time left. So thank you for that. Witnesses, before we go on, if you struggle with our Canada's alternate language, French, there is a button on your computer screen. If you weren't made aware, it looks like a world. You can pick the language you wish to hear this in. So that being said, Michel Thériault, vous avez la parole pour 6 minutes.
Mr. Thériault, the floor is yours for 6 minutes. Thank you, Mr. Chair. I would like to ask my first questions to Dr. Goulau. Firstly, thank you for accepting our invitation to come here today. Many people have talked about your system, your model, be these people on the left or the right. Many people have been inspired by this model. I've looked at some key elements of this model, and I'd like to discuss them. Firstly, some people say that there should be some type of criminal motivation for people to get treatment, and that decriminalization leads to chaos. What do you think about this?
Thank you for the question, but in fact, I do not agree. In fact, we are much more effective in joining and helping people in this framework of decriminalization than before. I must tell you that we lived for a long time under dictatorship here in Portugal, during which people did not even approach treatment facilities because they were afraid to be referred to the police. And in fact, decriminalization facilitated and turned everything much more smooth and with much more dignity, and a drop in stigma of people who use drugs. So I consider it was a very good step forward.
Before decriminalization, should we firstly ensure that we have integrated, well-organized services? You talked about a continuum of services. I'd like to hear you speak further to that, and if you still have the time. There is a Minister of Health here in Canada who has stated that either we're in a miserable situation or we focus on treatment. We need to put people in treatment centers. So he sees it really as two options. Do you agree with this? Do you think that there are other systems that would work?
I believe that the first thing to do is to assess and to better understand what are the needs of the person that we have in front of us, and what are the kind of motivation to their drug-related problems. This is the first one, because I also believe that we need to provide to people who use drugs the minimum levels of dignity before we can demand that they struggle for a change in their lifestyle. Okay, so first thing is, what kind? Does this person has a house? Does this person has access to health care in general? Does this person has the basic needs fulfilled? And only then we can work on motivation to change. So this is, that's why I'm talking about the continuum. And the continuum from harm reduction policies that are not an incentive to continue using substances, but the way to contribute to a better life and a longer life in any circumstances.
Some believe that harm reduction uses means that can lead to problems such as more chaos, poor behavior, complacency on the part of police authorities or different stakeholders. So, in your opinion, what's the importance of harm reduction in your continuum of care in order to increase well-being amongst these individuals?
This is the first step to approach people who are most disorganized and to gain their confidence in the health personnel, so we can establish a relationship, and this is the basis for the therapeutic work. So I think harm reduction, in fact, is key to approach people that otherwise we do not manage to reach.
Have you had issues with cohabitation in your region, and how have you dealt with these cohabitation problems?
I'm sorry, I do not understand the meaning for cohabitation. What?
Cohabitation, en fait, il y a par...
So by cohabitation, I mean the concept that we have supervised consumption centers, there are rehabilitation centers, the idea of co-location issues. Have you experienced issues with this, and how have you dealt with them?
On the contrary, I think this is the continuum I was talking about. We try to establish continuity in the levels of care that we can provide in any circumstances. And we do not give up from people in any circumstances. If, I'm not able as a medical doctor to motivate someone to step in a treatment center, a therapeutic community, at least I can contribute for that person to have the conditions to use with lower risks and continue working in other areas of his life.
Merci beaucoup, Michel Thériault.
Thank you very much, Mr. Thériault. Thank you, Dr. Goulau.
I promoted you to a Dr. Gord, and I hope you welcome that promotion. That being said, Mr. Johns, you have the floor for 6 minutes.
Thank you, Mr. Chair. And thank you to all the important witnesses for your incredible testimony and all of your work. Minister Williams, your government has had a significant growth in toxic drug deaths per capita, from 800 in 2019 to over 2,000 last year, the worst year on record, and now a per capita rate that's almost on par with British Columbia. And Paul Wells just wrote in the Substack the other day, said the scale of the crisis in Edmonton and across Alberta makes it hard to be sure of success. And he cited Deputy Chief Dreischel from the Edmonton Police Service, and he says that he's been in the Edmonton Police Force for 27 years. He said it's the worst that he's ever seen. We've also seen your government close safe consumption sites. You've opened one new one since you took form government. You've canceled 5. You've closed 2, and you plan to close 3. And the previous government had opened 8 new ones and planned for 2. Do you support safe consumption sites and recognize the importance they have to save lives?
Yeah, thank you so much for the question. Alberta's government continues to fund drug consumption sites, but our position is fundamentally that without an off-ramp out of addiction with treatment capacity being built, which is seriously across the country chronically underfunded, underbuilt, without that capacity, how do you expect somebody to ever get healthy? I mean, the purpose of a healthcare system should be about getting people care and treatment into recovery and healthy. So we fund them. But I don't think drug consumption site on every corner is going to solve this problem. We need a serious adult conversation as a country about what that off-ramp looks like. Alberta's putting a policy option forward that has largely been ignored by the rest of the country for the last 25 years.
Nobody is not saying that we don't need more treatment and recovery, Minister. I think all of us agree we need to scale that up. That is something we're all unified on. The importance of safe consumption sites. I'm going to ask Guy Felicella maybe to comment about those. And, you know, Guy, Mr. Felicella, you advocate for both harm reduction and recovery. Can you talk about why that is so important?
Yeah, most definitely. I mean, obviously, you know, dead people don't recover. You know, you also have a lot of people who don't struggle with an addiction that use substances. And with the risk of the contaminated drug supply that's on our streets today, you know, first-time substance users, intermittent substance users, or casual substance users, and people who struggle with addiction, all walks of life of people who use substances are at severe risk of death. You know, you don't have to have a significant. The unfortunate part is that when you have an addiction, it's like we wait for people to have this addiction before we actually help them. So treatment and recovery won't help people who just use these substances. Harm reduction services will, which a lot of them build the connections and services to build out other healthcare services. I mean, if you look at the 20-year impacts of Insight in the downtown east side of Vancouver, which has referred 71,000 people to off-site services, and many of those could be detox, treatment, recovery, health, hospitalization. Harm reduction is really a big connection piece, similar to what Dr. Gulau was speaking to build support, build the trust, build the non-judgment, compassionate relationship that's needed. And when somebody does make the leap, if you look at Insight, on the second floor, it has a detox floor. On the third floor, it has a transition floor. And I will say this, it wasn't recovery services that came to the downtown east side to get me out of there. It was harm reduction services that were giving me bus tickets, cab fares, to treatment facilities. And every time I left treatment, because it's a chronic relapsing condition, harm reduction welcomed me back, and I wouldn't be alive today without it. And so I'm a fierce advocate to understand that we need a full pathway, full continuum of care in this country that supports both harm reduction and recovery. Gone are the days where it's and or. It has to be both. This drug supply is killing people. And again, as well, like I said, not everybody who uses substances struggles with an addiction.
I'm just going to add to that. You talked about not everybody, has an addiction. Can you speak about, I mean, we talked about, Minister Williams talked about it being an addictions crisis. Do you want to comment on what you heard there?
Yeah, I mean, if it was an addictions crisis, look, you could look back to decades of past where alcohol consumption is the highest rate of addiction in the countries forever. It is like the number one drug. So if it was an addictions crisis, then why didn't we call it an addictions crisis 20 years ago? It's really a toxic drug crisis because the drug supply has just shifted and changed. Yes, sure, there is people who are struggling with addiction, who are using substances. I'm not denying that. But let's get real. What's killing people is the contaminated toxic drug supply. And some people, yes, they may struggle with an addiction. But again, being a chronic relapsing condition, I went to treatment over a dozen times. And the majority of people who go into treatment don't walk in the front door and out the back door and just, their life changes. This is a process. Recovery is a long journey for a lot of us, the majority of us. I think, one of the things that we have to look at and be real with is look at how do we treat death, people from dying, and then also how do we support people and treat addiction. But you can't treat addiction if people are dead.
Thank you. How much time do I have left, Mr. Chair?
10 seconds.
And can you speak about the importance of safe consumption sites?
Well, when you overdose there multiple times and you wouldn't have a beautiful family and the life you live today, 3 kids, a job, a career, a life, it just speaks to the importance that harm reduction kept me alive until I was able to find my recovery. So really grateful.
Thank you very much, Mr. Johns. Now, for the benefit of witnesses, the amounts of time in the rounds will change, so I just ask you to be mindful as I tell you how long they will be. We will now turn back to the Conservatives. Mr. Doherty, you have the floor for 5 minutes.
Thank you, Mr. Chair. I first want to say, Dr. Goulau, it's nice to see you again. Mr. Felicella, I want to say, as somebody that's from BC, I've followed your life and story, whether in the media, but also some of the talks that you've done in schools and publicly as well. I greatly respect you and appreciate your point of view and appearing on this panel today. Minister Williams, you have wrote an open letter to the federal government calling for common sense solution of traceability measures on so-called safe supply. You said your recommendation mostly fell on deaf ears. It went nowhere. It seems that this government is deliberately ignoring that diversion is in fact a problem and possibly, in fact, might be actively enabling it. Is that an accurate statement?
Yeah, that's an accurate statement.
You described diversion of so-called safe supply as a human catastrophe unfolding before our eyes. Can you elaborate on this?
Yeah, fundamentally, the addiction crisis we're in, and it is an addiction crisis. I need to point that out. Nobody walks down downtown Eastside Vancouver or West Avenue in Edmonton, or while I was wandering the streets in our beautiful city capital, and thinks that these individuals that are struggling, intermittently homeless, are not in active addiction. Speedballing methamphetamine with fentanyl in this crisis situation. It is addiction. We need to address that seriously. And if we're not adult enough to have that conversation, we're not going to find the right policies to solutions to it. Now, when it comes to the safe supply, what that does is it fundamentally increases the supply of opioids available to the public. So if you look at the Stanford Lancet Commission from the world's preeminent scientific journal, published with Stanford University, which is academically the authority on the North America opioid overdose crisis, the axiomatic rule that comes out of that report is effectively you increase supply and you will increase harms. It does not matter if the producer of the supply is a drug dealer and trafficking fentanyl from China, or is the Prime Minister Justin Trudeau that provides it through SUOP grants. The same biological fact of consuming the opioids will drive new addiction. You will have more supply, you will reduce costs, you will reduce barrier, you will increase access, and therefore increase harm. We saw this because the fundamental crisis we're facing was due to an overdose opioid crisis that was proliferated in the 1990s with Purdue Pharmaceutical and oxycodone, cynically propagated by them in the industry that moved it forward. We now see the Government of Canada repeating this again. And if they deny the diversion claims that Alberta believes are true, if they deny the diversion claims that the RCMP and Prince George and others have said are happening en masse with mass seizures of 10,000 plus pills, they can use evidence of a chemical tracker, which is approved as guidelines with the FDA in the United States to protect intellectual property for for-profit pharmaceuticals. Surely we can do that here in Canada. Surely if we have that ability to protect profits in the United States for pharmaceutical companies, why not protect lives and use the evidence that it is being diverted? Otherwise, I don't understand what they're afraid of beyond the moral and legal liability they have for propagating it.
Thank you, Minister Williams. Dr. Goulau, Portugal is often used, it is always used, as a gold standard in terms of dealing with a nationwide addictions crisis. Was Portugal facing a fentanyl epidemic when they implemented decriminalization?
No,
Okay.
sir.
What resources?
When we developed,
Sorry, go ahead.
no, when we developed our policies, we were addressing heroin epidemic. It was the biggest problem that we were facing at the time.
Dr. Goulau, what resources and infrastructure were put into place prior to Portuguese project?
Quite modest, sir. We are a country with limited resources, but we have been steadily stepping in the investment in the health service addressed to drug-related, to addiction problems. Nowadays, we have a mandate that encompasses not only the problems related to illicit substances, but also to alcohol, for instance,
Okay.
and even...
I just have one last question. Sorry, Mr. Goulart. You've mentioned the serious lack of wraparound supports and how important those are. Can you describe in detail the wraparound supports Portugal implemented?
Perhaps, Dr. Goulart, I'll have to interrupt you there. I'm sorry, Mr. Doherty's time is up, but you perhaps will have time to come back to that question. Ms. Sidhu, you have the floor for 5 minutes.
Thank you, Mr. Chair. Mr. Chair, I want to thank all the witnesses being with us. Special thanks to Mr. Filicella. Thank you for giving back to the community. And I'm posing my first questions to you. Mr. Filicella, very soon you will be celebrating Father's Day. You have a beautiful family. And what message do you have for the people who claim harm reduction has failed?
Well, I mean, it's pretty simple. I mean, my kids wouldn't be on the planet they came after, 2013. So the real big picture of it is that it's truly humbling that, what I was struggling with, a lot of childhood trauma throughout my life and how I viewed myself as a person in society, having the people in the supervised consumption site. It was overwhelming, and they were always the one that were constantly giving me options and talking to me about detox and talking to me about recovery. And I'd really built a relationship with those nurses there. They cared more than I cared. And that's why I kept coming back there. And, I was always I was good at getting sober. I was just never good at staying sober. And it took me a long time, but without the support of that supervised consumption site, I wouldn't be celebrating Father's Day. I wouldn't be celebrating anything I do. And, the impacts that I've also had for the school talks and the wisdom that I can pass on to these kids so that they don't fall down the same path as me. So that if they are struggling, that they do reach out. I mean, it's been absolutely a very humbling experience, but I accept my past for what it was. And I try to just, really have a balance of understanding that, there's a lot of people who just use drugs that don't have an addiction, and I don't want them to die. And so having facilities that support all pathways and all people as individuals is vital. And so, yeah.
Thank you. But what can provincial and federal government do to stop the flow of toxic drug supply? When you're going to school, you're talking to the kids, what resources need to be provided?
Well, I think, first off, we have to have a lot of it has to deal with all the aspects of the 4 pillars, which is, harm reduction, prevention, enforcement, and treatment, and having those flow right across the country. I think, obviously with the toxic drug supply, it's really just changed the dynamic of things that we struggle with. And so, in our sense of also, the education piece is just vital for kids to understand how dangerous it is to, use substances in today's day and age. And it's not the question of, me telling somebody not to do something doesn't stop them from doing it. So you also have to consider as well when you're educating people that if you are using these substances, please don't use alone. Please get naloxone trained. Please reach out for support if you need it. You have to just have the full continuum of care. We can't keep going back and forth and say we're going to, just like we're not going to prescribe our way out of this, we're not going to treat our way out of this by sending people to treatment and recovery, because there's a back end to that as well. People need employment. People need purpose. I didn't need somebody to tell me how to live. I really needed people to show me how to live. And that was the continuum of care with both harm reduction and recovery.
Thank you. Next question is to Dr. Glau quickly. Thank you for joining us today. Dr. Glau, I'm a member of the Interparliamentary Group Unite, funded in Portugal by your former colleague, Ricardo Batista. Could you talk to this committee about the debate in Parliament and in society you had in Portugal?
The debate around decriminalization, is it what you...
Yes.
Yes. Well, it was held in 2000, around 2000. It was a proposal of a committee who drew the first national strategy, and that included decriminalization. And in fact, it was quite easy to have the social support, the support of the population around this idea. And this, because at the time, it was almost impossible to find a Portuguese family that had no problems related to drugs. And everybody tended to say, and it was cross-cutting all groups of society. Of course, it affected mostly the most disorganized, marginalized groups, but it affected medium class, upper classes, political class, everybody.
I'm sorry, Dr.
So
Goulau, I'll have to interrupt you there, sir. Thank you for that. Et maintenant, Michel Thériault, vous avez...
Now, Mr. Thériault, you have 2.5 minutes. Dr. Goulau, could you continue, please? Continue your answer.
Well, thank you. Well, I was trying to explain that everybody had someone with drug-related problems at home, and people tended to say, my daughter, my boy is not a criminal, he's someone in need of help, in need of treatment, in need of support. So the social support to the idea of decriminalization was quite strong. At the parliament, things were a little bit more complicated, with a bipolarization between left-wing parties and more conservatives opposing the idea. But in any case, it passed. It was comfortable, the win of the proposal of decriminalization back in 2000. Yeah.
Pouvez-vous? Could you speak further to stigmatization and how this hinders one's ability to recover?
In fact, if we are dealing with a criminal, the way that the society looks at the person is different from the one that society has towards people who suffer from an illness. So, and the respect that is devoted to that person is different under a criminalization framework, or when you consider that you are dealing with a chronic relapsing condition, as Mr. Felicella already told us. I believe this makes a lot of difference, and even among health personnel, the attitude became quite different.
And this also has an impact on the individual's desire or ability to ask for help and overcome these problems, because it can have an effect on their job, an effect on their housing. And so at that point, they may end up in the streets. Unfortunately, Mr. Thériault, you can continue in your next round of questioning.
Merci beaucoup.
Thank you.
Mr. Johns, you now have the floor for 2.5 minutes.
Well, thank you, Dr. Golo, for being here. It was great to meet you in Portugal, and we can't thank you enough for taking the time to always help share policies that have worked for you in Portugal. Now, when I was in Portugal, I learned about your response at the peak of your drug-related deaths. Your country went from 250 people on methadone to 35,000. You engaged the military to build labs for affordability and speed. You scaled up treatment facilities, year-long treatment facilities across the country. You took a multifaceted approach to this complex issue, and your numbers have gone from 100,000 chronic substance users to 23,000 today. Do you see Canada responding in the way Portugal did to this health emergency, and what would be the recommendations you'd make to Canada?
Thank you, sir. Well, to be honest, I don't know in depth the reality in Canada, but I think the investment and the availability and to turn easy to access treatment facilities would be very, very important. So the investment, in my view, the investment in treatment and the harm reduction as it was already said, to gain the confidence and to trust of people is key to deal with these kind of problems.
Again, we constantly hear certain politicians state that Portugal has forced treatment, and the Dissuasion Commission is about forced treatment. But you've been clear that the Portugal model is not about forced treatment. Can you explain why the Portuguese don't believe that forced treatment is the answer?
In fact, we find that motivation and once again, providing people the minimum levels of dignity and allow them to make their choices is much more effective than forcing someone to do whatever he doesn't want to do. So as I believe that we are much more effective if we have someone homeless living on the streets with no dignity, no access to hygiene, to health care. If we provide those conditions, and then we can work on motivation to change the lifestyle.
Thank you.
That's where we invest.
Thank you, sir. Thank you, Mr. Johns. We'll now turn to Ms. Goodridge. You have the floor for 5 minutes.
Thank you, Mr. Chair. Minister Williams, education and prevention are key pillars of any good strategy to address addiction. I recently met with Dr. Victoria Burns, and she's at the University of Calgary with a program called Recovery on Campus. And I was really excited to hear some of the really innovative and wonderful work they're doing to promote recovery on post-secondary campuses across Alberta. I was just wondering if you could expand and share why the government of Alberta decided to create a program like this.
Okay, thank you for the question. It's a terrific organization, Recovery on Campus, and of course, Dr. Burns is an important part of getting that going, starting at the University of Calgary, 26 post-secondary institutions, where they focus on recovery and opportunities for those to live in campus life, but also live in the recovery at the same time. We fund it $1 million approximately a year. We want to see that program continue to expand. Interestingly, my first day I was sworn in as minister was June 9th last year, and my first event was that evening in a post-secondary institution at Red Deer Polytechnic with an event with Dr. Burns. And the first thing that happened to me upon going to registration is an individual came up to me and gave me this coin. It's a 24-hour coin, and I've kept it with me ever since that day. This person had been sober for 24 hours. And it's important. It's important for us to be able to grasp on individual instances of hope. And if you have a system that doesn't provide hope, if you have a system that doesn't fund recovery, that doesn't build beds, that turns harm reduction into some sort of marketing term rather than genuinely trying to help people, to convince people that when, instead of treatment, we'll put resources and funds into safe supply, sort of continuing to palliate this continued addiction of the highest powered pharmaceutical grade opioids or whatever the substance is, I think that kills hope for those who see a possible life. All of my office is in recovery. Our chief of staff in the province of Alberta is in recovery. These are people of immense capacity. I believe deeply that this coin that I have is the start of hope for somebody every single day when they get to touch on that. We as a province, us as a country, need to embrace that hope. Otherwise, we're sending a message of despair to those who suffer from this disease.
Thank you, Minister Williams. I know the government of Alberta has also made many other innovative moves, specifically investing in addiction recovery supports and the recovery communities. And there are 11, as you said in your opening statement, 11, and 4 are on federal First Nations reserves. Why did the government of Alberta choose to move forward with building recovery centers on First Nation reserves when First Nation healthcare is the responsibility of the federal government?
Because the government of Alberta sees this as a human and a question of dignity. These are Albertans like everyone else. We want to partner with our Indigenous community, and we're not waiting for the federal government to backfill the gap they've left. They constantly, First Nation chiefs, I came from meeting with Treaty 6 chief, they all want to see recovery. And the federal government, the only health care the federal government is truly responsible for is on reserve First Nation. And that seems to be the only health care they're not willing to deliver when it comes to addiction treatment for First Nations. The government of Alberta is spending millions, tens of millions of dollars in not just infrastructure but programming. Well, instead, we're asking the federal government to stop pushing safe supply pouring over our border from BC and other places. I just feel like they need to, you can't suck and blow at the same time.
On that point, I know you wrote a letter to the Minister of Mental Health and Addiction asking for a chemical tracer to be put on. We've now seen the government of British Columbia step on board because they've now admitted that diversion is actually a very serious problem from these so-called safe supply programs. I was wondering if you could share why the government of Alberta has asked for that, and how concerned are you about the diversion of this so-called safe supply program?
The government of Alberta has made safe supply illegal in the province. That's our right. It's our responsibility under the Constitution and the division of powers. We will continue to do that so long as we are elected as a government. However, what else would you have Alberta do now other than come and plead at this committee and write letters to the minister that go, unresponded to in substance? Because we see the safe supply being pumped into 65 million pills a year. Each one of those 8 milligram pills more powerful than street heroin. Pharmaceutical-grade opioids, unwitnessed, being mass distributed. What would you have Alberta do beyond oppose it here, make it illegal? We need the federal government to take action in what is the most radical policy in the world. There's nowhere else doing this. It's a failed policy. It's devastating. I'm all for what people call harm reduction, if it's naloxone kits, if it's drug treatment centers, if it's virtual opioid dependency program, needle exchange. But it becomes harm production when you become the purveyor of the hard, powerful drugs themselves, and we oppose it.
Thank you very much, Ms. Goodridge. Madame Brière, vous avez la parole pour 5 minutes.
Ms. Brière, the floor is yours for 5 minutes. Thank you, Mr. Chair.
I know, I'm glad to see you again first. I know Minister Sachs replied to your letter and offered that officials from Health Canada discuss with yours regarding the practical issue with chemical markers. Can you confirm if that meeting happened?
I'm happy to meet with Minister Sachs anytime on this.
Not with Minister Sachs, with the officials. In her letter, she said that she suggests a meeting with officials.
I'm certainly happy to see the officials reaching.
And
I think that,
can you confirm if that meeting happened?
I'll ask my officials if they have had the conversation. I think there would be a sense of urgency from the minister if she understood the consequences of diverted safe supply, high-powered opioids being mass distributed into our communities. We now admit from BC that diversion's happening. The consequence of this, we spoke to a researcher out of the United States in the addiction crisis, and he says that he believes there's as much opioids on the street now as there was under the high point of the oxycodone crisis in Canada because of the safe supply being distributed by this government.
Thank you. Dr. Goulau, happy to meet you, and thank you for joining us. Earlier during the meeting, a Conservative MP said wrongly that Canada is legalizing drugs. What will you say to anyone that says decriminalization and legalization are the same thing or a word play?
Thank you, ma'am. No, in fact, I tried to explain. Those terms do not mean the same. Legalization is the regulation, turn substance legal, as we consider alcohol or tobacco, and it's different from what we did. using drugs is no longer a crime, but under our law it's still prohibited. It's and is punished under the administrative law. So our society continues to give a clear sign of disapproval to drug use. And I think that this makes the difference.
Thank you very much. I'll switch in French. Que pensez-vous?
What do you think, Dr. Goulau, of Alberta's approach investing in treatment instead of in a continuum of care? To take the minister's words, an approach that makes the choice between a miserable existence and mandatory treatment.
I believe in the continuum of supplying the responses that the person needs. I believe those responses must be built according with the concrete person that we have in front of you. So massive policies that offer the same thing to everybody, I do not believe that they are really effective. We must have an individual plan for each person. So, and this continuum comes from we have a new plan, a new strategic plan here in Portugal, and it stands in 3 pillars: empower, care, and protect. And we developed our policies around those 3 ideas, according with the life cycle, with the context where the person lives and where it evolves. So I think an individual plan is key to be effective for each person.
Thank you very much. Mr. Felicella, j'ai été très touchée par...
I was very touched by your testimony. Thank you for sharing this with us. I also appreciated you saying, I do not want anyone to tell me how to live, but rather I would like them to show me how to live. In your opinion, are all drug users able to follow treatment successfully?
Well, I mean, you have to look at the individual, what they're learning in treatment, the ability to, look at life-changing avenues. And it's easy to say to people to go to treatment. It's just very hard to stay sober. And, treatment or completing treatment doesn't guarantee that you're going to be sober either. And a lot of the times people need the back end support after treatment, and they need to be shown how to get their ID back. I mean, I needed to know how to pay off past debts. I needed to go get my driver's license. I needed to know how to do a resume. You really have to teach. There's so much more that goes on than just getting off the drugs. You really have to create a new life where it's easier not to go back to the substances. And that
I'll interrupt you
is
there,
very
Mr.
easier than said than done.
Felicello. Madame Briere, that's your time. Thank you. Colleagues, we'll now turn to Ms. Goodridge. You have the floor for 5 minutes.
Oh, okay. Thank you again. Minister Williams, as has been kind of put forward, people like to accuse Alberta of not supporting harm reduction, and I know that that's nowhere close to the truth. So can you speak to some of the innovative plans you guys have in place, programs, specifically the narcotic transition program? Because I think that people seem to think that the only possible way of dealing with this is to give so-called safe supply and flood the streets with more narcotics rather than to do it in a medical model. So I was wondering if you could explain a little bit around what you guys are doing with that.
Yeah, thank you for the question, of course. I'll be honest, I'm disappointed in the national dialogue around language like harm reduction, safe supply. It's unfortunate they've effectively become marketing terms meant to convince Canadians of something that they intuitively know doesn't work when it comes to safe supply, for example. I kind of don't care the label anymore. If you have a policy internationally anywhere that wants to get people healthy, then I will adopt that within my program. We have the Narcotic Transition Services, as you mentioned, MP Goodridge. We have the drug consumption sites. We have the Digital Overdose Response app. We have Virtual Opioid Dependency Program, which is the world's first, most innovative, immediate, same-day access to evidence-based opioid therapy for buprenorphine products like Suboxone, Sublocade, products like methadone. 8,000 Albertans a day get access to that. We have mass distribution of naloxone kits. Some people call all of that harm reduction. Some people don't. That's fine. But if you call harm reduction handing out high-powered opioids at a pharmaceutical grade, unwitnessed, mass distributed into our community,